It is my pleasure to introduce 4 speakers today for our master's presentation. I really want to thank those of you that have been with these students for the last few months as readers. I want to also thank the advisors for all your help. So this is definitely an exciting part of our whole master's program. So we're really looking forward to this. Our first speaker, Carinna Emilio. She comes to us from SUNY Stony Brook, and she has majored in 2 things. So women's and gender studies, as well as a Bachelor of Science in Nursing. So the title of her presentation is called Missed Opportunities in STI Screening of Pregnant Women, a study of the literature and practice patterns concerning STI and perinatal infections.
So thank you. So my name is Carinna, and I'll start my presentation for you guys today. It was mentored by Dr. Jonathan Zellman. He is an infectious disease professor and physician at the School of Medicine. I don't think he was able to be here today. Okay, so just a little background information. Sexually transmitted infections have continued to rise over time, and even during the COVID-19 pandemic. In the United States in 2019, there were about 2.5 million cases of gonorrhea, syphilis, and chlamydia, and there was actually like a 30% increase from 2015. And on the left screen here, you can just see this is like a little fact sheet from the CDC, and this is the most updated info they have from 2021. It's just a state of STDs in the US, and they still continue to increase even today. And STIs are really important to study and prevent because they increase your risk of getting other STIs. So if you have one infection, you're more likely to contract another one, including HIV. They can lead to long-term physiologic issues, so pelvic abdominal pain, infertility, the inability to get pregnant, related pregnancy complications. They can actually lead to issues with the newborn at birth. So this has been something that the CDC in the US has been really looking into. And I was actually really interested in this because for those of you that don't know, during my 2 years here at Hopkins, I was an L&D nurse at the main hospital across the street, and I was really interested in the high rates of congenital infections that they had in the area, especially in Baltimore. So I decided to kind of look into this with Dr. Zellman because he's also a physician over at Bayview. But really, he has a history of looking into these things. He worked with like the CDC and everything. So I felt like this would be a great project for us to get into. So perinatal infections, again, infections during pregnancy. There was about 5,726 cases of syphilis in pregnant women, which was an increase from 2019. Rates of syphilis among women of childbearing age, that's 15 to 44, is also increased. Here in Maryland, we saw a 53% increase in gonorrhea, chlamydia, and syphilis from 2009 to 2018. We also saw an incredible 222% increase in congenital syphilis in the area from 5.5 cases to 12.2 cases. And congenital syphilis has really increased in the neighborhood in Maryland, Washington, D.C., and Virginia. So this is obviously something that like the main hospital in Bayview can look into to kind of improve and see what we can do to prevent these infections. So for my project, it was a standard integrative lit review. I used the Johns Hopkins EBP model, which is created by the Center of Nursing Inquiry here at Hopkins. And they have like a PICO question that they use to kind of start the project off. So my project is basically the same thing as the title. Are there missed opportunities when healthcare providers are screening for pregnant patients? And if so, what are the best practices for these processes? So P would be like patient population, so obviously pregnant individuals. Interventions would be perinatal screening, best practices. The C would be comparison with other interventions, so our current screening guidelines, if there are any, or what we're already doing before. And it would be the outcomes, so that would be the decrease in perinatal and congenital infections. So I'll just kind of like breeze through the methods because it can get a little like detailed, but I did use the EHP model. I included all articles that were in English and within the past 4 years. So this was started last year. So I'd say 2018 to 2022. I didn't limit myself to the United States only. So there are some international studies in here. Inclusion, exclusion factors. So of course, pregnant individuals, perinatal, antenatal care, guidelines, policies, recommendations for screening. Exclusion would be non-pregnant individuals, all other STIs. So at the beginning of the study, I mentioned gonorrhea, chlamydia, and syphilis. Those were the 3 STIs of contact, and then any non-English journals, of course. It was limited to PubMed, Embase, and CINAHL Plus, which are the search engines that Johns Hopkins University has. You can see the mesh terms here that I included. I started with about 171 articles that were imported. Then, I went through the process of removing duplicates, title and abstract screening, full text review, anything that was irrelevant was removed. And I ended up with about 6 articles. And then these articles were then assessed for breakdown on quality and relevance. So of the results, the six articles that resulted, they were found to be about B, which was about moderate quality, and the ABP model has like a specific guideline of how they determine these qualities and how we break it down. 4 were determined to be level 3, so this was including non-experimental and qualitative studies, and 2 were level 4, so that's like a clinical practice guidelines or consensus panels where they had like experts in the field discussing policies, and you can see them all here on the right. This is just citations for them. So overall, there were some consistencies and discrepancies in the literature, population characteristics and demographics. So all studies except one, and this was a study from Indonesia, could actually clearly differentiate data on pregnant patients versus non-pregnant patients. So this kind of came down to like poor demographic intake and provider documentation. In some places, all patients, regardless of whether they were pregnant or not, were actually just like screened altogether. And so that made it difficult for like screening policies and guidelines to actually be followed, because we didn't know if these were all pregnant patients versus non-pregnant patients. So policy and guidelines, there were differences between providers at the same facilities, and then differences in the facilities, like maybe in one facility in one area, and then in the next city that would be different, and that varied even among states, which was very surprising to me that there was such huge differences, especially like within the United States, about how we screened, even though like the CDC has like recommended guidelines for how we do that. Providers and hospitals were actually, depending on like the state and facility, were actually able to do something different. Again, provider documentation and cultural taboo. So even the way that providers like documented demographics on patients and what we would define as like quote unquote high risk factors led to missed opportunities. There was no solid definition of what high risk was, even on like the CDC website. So that really came down to what providers determined was high risk. Social taboos. This was something that was probably more prevalent in the study that I saw in Indonesia. Certain providers were actually like concerned to ask about maybe high risk factors like multiple partners or anything like that with patients, because some patients felt like it was almost like an offensive thing to ask. And so there was poor screening on that end. That, if we can't account for these things, then we don't know that we need to screen for them. Treatment plans, I think this was probably the most interesting thing that I found in the study. So antibiotic regimens and treatments affected the way providers manage screening. So there was a screening from Canada, study from Canada, I found that said that providers were actually less rigorous in their syphilis screening if they knew that infants would be getting erythromycin ophthalmic solution, which is an eye drop that we give at delivery to prevent infections in the newborn. I thought that was really interesting. I had no idea that, I feel like I didn't know providers would kind of like lean into one thing more than the other. I know that there was actually a shortage of erythromycin, I want to say like 3 or 4 years ago. So I'm wondering what providers were doing at that point when they knew that that was kind of not like the fallback that we were going to use. So I just thought that that was probably the most interesting topic that I came across in a lit review that I was doing. So again, perinatal screening is not uniform throughout the United States in particular. It's often left to state and provider discretion. So certain states actually could define like what they considered high risk for their screening. So for example, I'm going to just use a random state because I can't remember one off the top of my head, but if like in Nevada, their rate of gonorrhea was quite low, maybe lower than the national average, that hospital could actually determine that they themselves were low risk and therefore did not need as much screening. I thought that was pretty interesting. Like where I used to work in New York, we would automatically do a third trimester HIV screening, for example, on all pregnant patients, regardless of factors, because the area of Brooklyn that I worked in was considered high risk. Whereas if this patient had maybe delivered in like Nevada, for example, they wouldn't have had to do that. Like they wouldn't have had to even follow up with it because the whole population is considered low risk. There was limited consistent data on how providers can assess and document high risk. Again, providers didn't know to ask if patients were in like relationships where there were multiple partners, if they were perhaps using condoms with their partners. So things like that, discrepancies in screening where treatment is involved, again, like providers being less rigorous for treatment if they knew erythromycin was going to be administered. This is something I actually think is really important because I know that we're facing some issues with gonorrhea, for example. It is considered a curable infection now, but however, it's estimated that by 2025, it will be mostly resistant to all the treatments that we use for it. So that's definitely something that we need to like think about when we're just kind of using like a blanket treatment for all infections that might pop up rather than uniformly screening all patients. Situations where a patient receives care from a facility that doesn't routinely care for pregnant patients, that's also really important. I'm thinking of situations like in my clinical experience, we would have patients who maybe like presented to emergency rooms for whatever reason they needed some sort of like immediate care. They couldn't get into an OB clinic or they didn't want to go to a clinic or a provider that wasn't their primary OB provider. They would go to the emergency room, and a lot of times these providers don't know that they should maybe do certain screenings. For example, if a patient shows up at 36 weeks, it's kind of like normal and commonplace to do like a GBS, which would be like a vaginal swab, maybe also follow up with their trimester screening. They're kind of falling through the cracks here. So maybe having like OB providers like in the ED or these other locations so that these patients do end up getting the treatment that they need. Also should consider extragenital screening. That was also really interesting. So one of the studies that I found surveyed women in the Dominican Republic, and a lot of patients were actually participating like extragenital sex. So they would have like anal sex, for example, and providers didn't know to ask or screen for these orifices essentially. And what was really interesting is that so basically WHO guidelines recommend doxycycline for sexually transmitted infections like gonorrhea, and I'm sorry, not gonorrhea, for chlamydia during pregnancy, but this can't be used during pregnancy because it's contraindicated. So they will recommend erythromycin 1 gram for cervical chlamydia, but it actually doesn't, it's not as effective in rectal chlamydia. So you're having patients who are being treated for one thing and not the other, and that can cause infection to actually spread to both orifices again. You can actually have reinfection in patients. So it's definitely something that providers should consider when documented like these high risk factors for infection in patients. Poor data surveillance and documentation again. I'm thinking of this study from Indonesia where physicians weren't documenting properly like demographic information on patients, and so the data then gets skewed. Like, is this treatment, are these screenings actually on pregnant patients or are they on others? Are pregnant patients actually adequately getting screened? I would say not so much an issue here in the United States, especially with our electronic medical record system. I know Epic is very good for kind of like pinging providers like, oh, at this point we should be doing X, Y, and Z screening. But maybe for other electronic medical systems, it's like not as adequate. So that's something that we can look into as well. Limitations of the study were done by me, independent. They were disregarded if they were non-English or if there was no full text, if I wasn't able to get it through Johns Hopkins, and I was limited to the search engines and journals that were available through Johns Hopkins. They reviewed prenatal care systems of health, which may have preferenced higher middle income nations. And it also, the search used heavily gendered language in its terms. So example, like pregnant women, but I had noticed that more recent studies will say like pregnant persons or pregnant people or individuals. So moving forward, I think the studies that look at this kind of data will have to also like use that as an inclusive term in their studies. So in conclusion, based on the synthesis completed, there's good, consistent evidence and results that there are missed opportunities in perinatal STI screening amongst providers and healthcare systems in the US, including other places, but mainly in the US, I think it's easier for me to talk on. Supports the idea that stakeholders such as hospitals, prenatal care systems, and major organizations like the CDC and the ACOG may need to reevaluate current screening standards. I definitely think that's an issue, like at the bedside. There's so many times I can think of where I was practicing where like a patient would come up positive for some sort of like STI during her pregnancy and then gets to labor and delivery. And we're thinking like, actually we should have maybe also done like an HIV screen or something like that, because if she was exposed to one thing, who's to say she wasn't exposed to other things? So there definitely wasn't really like a consistent way to know to do these things. And it definitely fell on like, for example, when I was a nurse, it fell on like my shoulders to screen for these things. And, at that point, I feel like it's almost too late, at delivery for us to be looking for these things. So definitely like having better screening practices prenatal to prepare patients for when they get to labor and delivery. I think babies will have better outcomes as well, especially if we needed treatment, earlier, better outcomes. So I just want to acknowledge, say thank you to Dr. Zendelman. He was my mentor for this project. Again, he wasn't able to be here today. And also from the American Sexually Transmitted Diseases Association, I was able to do this project through my summer fellowship through them. They have really great small project funds and fellowships if anyone's interested, and they're always looking for people to apply. So thank you again to them.
Thank you so much, Carinna, so much. Great job. So Anya is asking, what are some reasons why some states may have stricter STI screening rates than others? Why wouldn't something like this be more universal?
Again, I honestly just feel like based on STI rates to begin with, some states may determine that they are in fact lower risk, and just kind of like the issue we see with like laws and policies in general here, states kind of have jurisdiction over their own basically over their own laws and hospital facilities. So they may determine that something is not as big a deal as other states based on rates of infection. And that may just allow them to kind of say like, oh, we're going to do this, we're going to do X, Y, and Z. And providers like clinicians are more like independent in how they practice. So you might see that some providers kind of practice more preventative care where they're saying, I just want to screen everyone. I don't want anyone to fall through the cracks. Where some may say, well, based on what I've determined on our first prenatal appointment, I actually don't think this is an issue. So it really depends. And the CDC has like recommended guidelines, and providers may just kind of follow those and then limit it and then not do extra. But because they're following what's like our most basic guidelines, they're kind of doing everything at that point that they may need to, in their eyes, their facility's eyes, to prevent these infections.
Great job, Carinna. Very interesting information. Are there any missed opportunities for screening that you have seen during your own clinical practice that you think can be improved upon?
Yeah, I definitely think like what I mentioned, like at the end, where how like patients would come up positive for something in their pregnancy, and then they would come to labor and delivery and they would deliver. And I'm thinking of like one night where I was working, and the nurse practitioner from the nursery actually came to me. She was like, hey, like, do you mind like rescreening this mom for everything? Because she was never like rescreened, and the baby's already here, and we need to know if the baby needs to be screened or if the baby might need treatment. And that's like a huge problem, I think, because for example, if like this mom had never been rescreened for HIV and then this infant had been born with HIV, we're talking about like a delay in AZT treatment. We're talking about like how this infant could have like a higher viral load than we were expecting. This mom also being at risk, and now she's been breastfeeding the whole time. So there's just like so much that could have happened in the 36 hours from her arrival to her delivery to the infant being born, that we could have like missed these things if we had not been like adequately rescreening according to like set guidelines on how we were supposed to screen. So definitely something like that being done, and then maybe being like uniformly told to everyone would have been more helpful. There's only so much I feel like we can do when we deliver at that moment. They're only with me for like a shift or two. So definitely moving forward, maybe like educating nurses on what to look for when patients come in, so we know, okay, on admission, I'm going to do her IV. I'm also going to draw these labs that, you know, to screen for these infections.
Next speaker, and that is Ruby Ahaiwe, and you can go ahead and put up your slides while I introduce you. So Ruby graduated from Bowdoin College with a BA in biochemistry. So the title of her presentation, as you can see, is called Determinants of Young Women's Contraceptive Knowledge and Services in Nigeria. So welcome.
Thank you, Kristen, for that introduction. And welcome everyone to my presentation. Today I'll be talking about Nigeria's contraceptive framework. So basically, in Nigeria, Nigeria's population makes up 2.6% of the world's total population, and Nigeria has a high fertility rate of 5.3 births per woman. We also see a high maternal mortality rate of 576 maternal deaths per 100,000 live births, and low rates of contraceptive use. Interestingly, again, abortion is illegal in Nigeria, and so this means that women who choose to have abortions usually go through unsafe procedures and usually end up with serious complications. And so these factors show that family planning is indeed important, and women need access to adequate sexual and reproductive health services. And so here, I wanted to highlight Nigeria's the rates of contraceptive use among Nigerian women generally. And this image is gotten from PMA study conducted in Lagos, Nigeria. Here we see that majorly women use condoms and pills and injectables to prevent pregnancies. And so we wanted to understand how Nigeria was having an unmet need for family planning. And so this trend data was obtained from the Demographic Health Survey, and it shows Nigeria's trends in unmet need for family planning for married women for over a period of 28 years. This rate currently in 2018 is 18.9% of unmet need for married women. And now looking at all women in Nigeria to explore their unmet need for family planning, we see that all women have an unmet need still in 2020 of 18.4%, while married women's rate of unmet need increased to 23.6% in 2020. And so exploring barriers to contraceptive use in Nigeria, we have socioeconomic factors such as poverty, sociocultural factors, educational status, which influence women's choice to use or not to use contraception. Their partner influence for women who are partnered or married also can affect whether or not they choose to use contraceptives. Some women worry about misinformation or worry about side effects, and this often comes from them being misinformed about how contraceptives work or how family planning commodities work for them. And so here we can see, again, using a survey data gotten from PMA and conducted in Lagos, Nigeria, it shows us that health concerns, lack of need, whether it's due to abstinence or willingness to get pregnant or for menopausal women, and also marital status of not married, are the major reasons why women are not using contraception. And so for my study, we were very interested in whether religious factors were also a strong influence to contraceptive use among women. And now this is because in Nigeria, the majority of Nigerians are religiously affiliated. We have Christian Catholics, people who 45.9% of the population identifying as Christians or Catholics, and 53.5% of the population identifying as Muslim. Now there's the other category, which includes traditionalists, atheists, and other religions at 0.6. But for this study, we were mostly interested in Christians and Muslims. And so we started analysis using PMA data conducted in Lagos and Kano, two vibrant, prominent states in Nigeria. And we used data to do all analysis. Here we hypothesized that religious affiliation is a strong factor influencing contraceptive use among women in Nigeria. And in this slide, the first thing we decided to explore was women's marital status. And here we see that 87.8% of respondents in the PMA survey data that we used were married or living with a partner, while 12% were not married. Now, looking at the percentage distribution of female respondents by religion, we see that 56% of our respondents identified as Muslims, while 43% identify as Christians. Also, we explored the distribution of female respondents by the current use of contraceptive methods, and we see that only 32% of respondents use contraceptives, while 67% do not use contraceptives. Now, with this result, we wanted to explore again why women were not using contraceptives and whether they do plan on using contraceptives in the future. And so here we explored the intention to use family planning among current non-users, here we find that among the 67% of respondents who are currently not using contraception, only 39% plan to use contraception in the future, while 49% do not intend to use contraception in the future. Interestingly, we also have about 12% of people who are not currently using contraception who say that they do not know whether or not they will use contraception in the future. Again, we decided to analyze the association between religion and intention to use family planning in the future among non-users, since they were the larger group. And here we see that Catholics, or the Christians and Catholics respondents, were the most grouped to want to say yes to using contraception sometime in the future, while Muslims were not willing to, were more on the were not willing to use contraception in the future. Also, interestingly, we see that about 14% of Christian Catholics don't know whether or not they will use contraception in the future. Again, we explored the percentage distribution of respondents by their level of education and religion. And here we see that more Christians had achieved higher education in contrast to their Muslim counterparts in this study. Looking at the third row, you see that majority of the respondents in this survey had achieved secondary education, while more Muslims had only achieved primary education. And so looking at the percentage distribution again of respondents by residents, we saw that more respondents in the survey were living in urban areas versus rural areas. And initially we had analyzed for intention to use contraception, and we had seen that there were more Muslims in rural areas who were currently not using contraception and who are not intending to use contraception in the future. And so we decided to adjust for religion and area of residence, and we found that all of the respondents who are in the survey live in rural areas. Again, we decided to perform a multinomial logistic regression to examine the association between religious affiliation, age of respondents, and their intention to use contraception in the future among non-users. And here we see that Muslims had a lower risk of saying yes and don't know compared to the Christian women with regards to intention to use contraception in the future. Here we also we included additional covariates of age, education, and wealth. And after adjusting for these covariates, we see that the relative risk for yes is no longer significant, but the relative risk for don't know still remains low. And these results suggest that religion remains an important determinant of contraceptive use intention among Nigerian women. And it's also important to note that this results could be affected by education and wealth, as you see here. And so based on these results, given that religion seems to play an important factor as to whether women choose to use contraception or not, I wanted to discuss Nigeria's commitment to FP 2030. So Nigeria has committed to increasing family planning access and choice from 12% of modern contraceptive use to at least 27% by 2030. And as such, family planning has become a national priority. And therefore, it's important to engage religious and traditional leaders as allies in family planning advocacy and strategy development. And so other stakeholders for family planning policy priorities include the Federal Minister of Health, senators and legislatures at the national and at the national and state level, honorable commissioners for health at the state level as well. And with private sector involvement, again, we highlight reproductive health agencies, family planning advocacy groups to include religious groups, and to encourage religious groups to continue to become allies and advocate for family planning. Also, we know that private firms and international organizations do support family planning choice and expanding access to all women, regardless of intention and religious affiliation. And so the limitation in this study include that we only sampled the PMA data that we used in the study was only taken from 2 states, which are Kano and Lagos, as you can see from this graph. And the results could change if all states, or at least 50% of states in Nigeria, would be included in the study. And therefore, we do not think that it's a representative sample for all women in Nigeria. Again, given the small amounts of women that were included in the study, and given that there are over 36 states and it was just 2 states that were included in the study. Though it's also important for me to mention that data acquisition in Nigeria is difficult. It is difficult to find or to get data that is trustworthy and reliable. And so hopefully sometime in the future, PMA can sort of expand their reach to other states in Nigeria. So future directions can include, again, the adequate data collection for further analysis to explore the relationship between religion and contraceptive use. Again, discussing the results that we saw with the urban-rural differences. We think it's also important to continue to evaluate how area of residence affects women's intention to use contraception. And we also hope that there'll be an exploration of how religious factors continue to affect, especially adolescents and young women, young unmarried women, their awareness and use of family planning services. So I'd like to say a big thank you to Professor Alison Gamil, an assistant professor here at Hopkins in the Department of Population, Family and Reproductive Health, for her assistance, guidance, and support throughout this research study. I thank the Performance Monitoring for Action, PMA, for the data that I used in the study, my advisor, Sabrina, who helped me with, again, substantial work experience with the Gates Institute and Pathfinder in Abuja, Rotary International for supporting my education here at Hopkins, the Nigerian community, of course, and my friends and family. Thank you.
Wonderful. Great job. Tanesha has written a question in the chat right away. So awesome job, Ruby. Very interesting work. Did anything surprise you about the data research process?
Yeah, thank you, Tanesha, for that question. I think the most surprising part, and we were hoping to further explore, was with respect to urban-rural women living in urban versus rural areas and their intention to use contraception, because, like I said earlier, when we had done the preliminary analysis, we had seen that more Muslim women who were in rural areas were choosing not to use contraception in the future. And so we were very curious as to whether that was representative of the whole population. But then after adjusting for religion, we see that in this particular sample, all the women who live in rural areas are identified as Muslim, and there weren't any Christian living in rural areas in the study. And so hopefully with more data and, with more data, especially that cuts across more states in Nigeria, I do think that those results would probably be very different.
I have a question, Ruby, and I'm just wondering, a few years ago, I used a national representative data set out of Nigeria. I think it was called the National Health and Reproductive Health Survey. Is that still going on? Do you know?
So Allison and I really tried to find data, but I think it was just the PMA one because we used, I forgot to mention this was data like gotten from 2020 and 2021. And so most of the national data that, I checked when I checked the Federal Ministry of Health websites were just from say 2018 and below. And I didn't think that I wanted to explore. I just wanted to see like more recently what was, the situation.
Agree. Yep. Great. And I see Allison that said that the PMA data had more detailed measures. Okay. About
yes, and it was a household survey, right? So it had more questions that were very tailored, and so we could pull out, covariates and like decide on what particular co-founders that we wanted to explore.
Okay, well, Ruby, wonderful job. This was great. I will introduce the next speaker, Tanesha Mondestin. And she graduated from the University of Maryland, College Park, and she majored in both public health science and anthropology. So Tanesha, whenever you're ready, you can go ahead and share your slide, but I will introduce your presentation, and that is entitled Haitian Women's Birth Equity, a case study of the maternal health crisis for Black migrants in the United States.
Okay, thank you. Thank you for the introduction. As stated, my name is Tanesha Mondestin, and I'll be presenting on Haitian Women's Birth Equity, a case study of the maternal health crisis for Black migrants in the United States. So I did want to make a note that I do recognize that there are birthing people who do not identify as women. However, culturally, birthing people is not a term that is necessarily defined or understood, so I will be using Haitian women throughout the presentation. So the objectives of the essay was to really start a conversation about adverse birth outcomes for Haitian women in the United States, while also discussing a call to action for more research to be done in this area. This is more so to show how Blackness is not a monolith, and that placing all Black people in the category of African American / Black on census data or when they go out to fill out paperwork isn't always helpful because different groups can experience different outcomes. The methods. So one of the most challenging aspects of this research was finding actual literature for the specific birth outcomes for Haitian women. So I really want to thank the librarian Lori Rosman for assisting me with finding additional research papers. Although I wanted to focus on the US, I ended up using data from Canada as well. A major help for this paper was a report that was written by the New York City Department of Health and Mental Hygiene that focused on severe maternal morbidity and mortality within the city. Lastly, my field placement with the Haitian Women's Birth Equity Program really helped frame the paper. So there's a Black maternal health crisis, and this has been in the media often, especially since the CDC report came out earlier this year indicating that maternal mortality rose yet again in 2021. The Black maternal health crisis is a global crisis. Haiti has the worst maternal mortality rate on the Western Hemisphere, and the US has the worst maternal mortality rate among high-income countries. Now, Haiti is a low-income country, so these numbers aren't so to compare the countries, but it's more so to say that sometimes women coming to the US to give birth, they don't necessarily have better outcomes. Haiti's outcomes are more so based on poverty, but here in the US, we have to deal with discrimination and structural racism. According to the American Community Survey, there are a little over 1 million Haitians living in the United States. I think that this is an underestimation because there has been an influx of Haitians coming to the US due to tragedies such as natural disasters and political instability, such as the rise in gang violence, rape of women, kidnappings that rose, especially after the death of President Jovenel Moïse in 2021. So Haitians primarily speak Haitian Creole and French. Now I want to emphasize Haitian Creole because 80% of the people in the nation, they mostly speak that language instead of French. And English is not a national language, and that differs from many Black migrant groups in other countries who have English as a or Spanish as a primary language. There are a high cluster of Haitians living in cities such as Miami, New York, and Boston. So my focus is particularly on severe maternal morbidity. There are many research articles that focus on maternal deaths in the US, when SMM affects over 60,000 women every year. So for every maternal death, there are an estimated 100 mothers who experience severe maternal morbidity. According to the American College of Obstetricians and Gynecologists, they define SMM as unintended outcomes of the process of labor and delivery that result in significant short or long-term consequences to a woman's health. So the ideal outcome for deliveries are to have uncomplicated births. Since we know that 80% of maternal deaths are preventable, if we start to focus more on how to reduce morbidities from occurring, this may help to reduce maternal deaths. A woman who experiences a traumatic birth experience or nearly dies during the process, this is something that we can learn from. So we can learn about what went wrong and how we can improve things in the future. So what's the problem? Of all women, Haitian immigrants have the highest risk of near-death pregnancy complications in New York City. So Haitians are often grouped in a large Black/African American category, which misses the unique health needs of this group. So this is a table from that report that was written by New York City's Department of Health and Mental Hygiene. So you can see that Haitians have a rate of SMM of 494.0 per 10,000 deliveries. So why does this happen? Haitian migrant mothers reported experiencing more racial bias than other migrant groups. This is due to structural racism, language barriers, lack of culturally competent care, implicit biases, and triple quote-unquote minority status. Historically, in the 1980s, the CDC published their 4-H Club to describe that being of Haitian origin was a risk factor of having HIV/AIDS. So although this risk factor has been long dispelled, there's still distrust between Haitians and the medical system and is still present, as there is a lot of shaming of Haitians, and this stigma still lies when Haitians go to their doctor's appointments. So to continue and expand on the triple minority status, I came across in the literature, I think this can even be considered a quadruple minority status, in the sense that there are more intersections involved. First, the race, being Black. The race for SMM is 2 to 3 times higher for Black women. And being a woman already, we face a lot of oppressive factors in society. As stated before, the maternal mortality rate worsened in the US in 2021. Thirdly, being an immigrant. There's a lot of hostility and stigma that is high for Haitian migrants because of the case of xenophobia being racialized. So not only are they being discriminated against because they come from a specific country, Haiti, but they're also being discriminated against because of their race, being Black. Lastly, being Haitian in general and Haitian Creole speaking is another risk factor. So we have Haitian Creole speaking Haitians had 5.5 more stillbirths than non-Haitians. And this was from a study based in Canada. I specifically mentioned Haitian Creole speaking because some Haitians speak more French than they do Haitian Creole. So French is huge national language. So there are more resources available in French than there is Haitian Creole. So I completed my field placement with a nonprofit organization based in Brooklyn, New York, called Life of Hope, with their Haitian Women's Birth Equity Program. The general goal is to ensure that Haitian women have access to the resources needed for a safe and healthy pregnancy and birth. To do this, we want to work with providers to include more information in Creole, as well as having interpreters. We also want to establish a targeted health information initiative and coaching program for Haitian Creole and French-speaking women with chronic diseases or high-risk pregnancy concerns. So these are a few pictures that Haitian Women's Birth Equity Program does. I'm on the left-hand side of the screen. So we have pictures from various programs, support groups, community baby showers, and English as a second language classes. So finally, research. The recommendations. It is time for action. Research, cultural competency training, advocacy, and tailored programs are very important to advancing the initiative for Haitian women's birth equity. So in research, more research in this area will allow it to be pinpointed that there is an actual problem. So Dr. Pardo, my preceptor, is currently in the IRB process, and the hopes is to publish several papers to add to the literature. So cultural competency training that includes value to diversity and appreciation for cultural differences, especially in cities with high populations of migrants, such as New York City, Dallas, Boston, and Miami. This would be extremely helpful, especially to have interpreters available upon request and translated documents in the Haitian Creole language. Tailor programs. With New York City publishing this data, the New York City Department of Health and Mental Hygiene has crafted programs that tailor to migrant communities by partnering with community organizations that are already doing the work within those specific communities. So Life of Hope has worked in the Haitian community in the East Flatbush neighborhood since 2006. So their work with the health department has really helped to support programs like Haitian Women's Birth Equity. Lastly, advocacy. Santé Femme C'est la Vie is another program that Dr. Pardo spearheads under Life of Hope. And the slogan is, Si c'est pas nous, qui est? If not us, then who? We need to build more advocates for migrant health in general, because their birth matters too. Here are my references, and I wanted to do some acknowledgments. Thank you to my advisor and reader, Dr. Donahue and Dr. Jimmel, who were very supportive of me while going through some health challenges during my program, and also Dr. Pardo, my preceptor, who gave me the opportunity to learn from the work that she is heavily involved in, as well as my family and friends. Thank you.
Yay! Great job, Tanesha. This was so interesting. Anya is asking, you mentioned that Haitians have unique health needs compared to African Americans. So what are some of those unique needs?
Thank you for the question, Anya. So Haitians, when they have health concerns, such as if a birth were to go wrong, they have a miscarriage or a stillbirth. Some Haitians, there are Christians, Catholics. We have also people who believe in voodooism. So in that case, some situations they might believe came from supernatural sources. So in other instances, they may not go to the doctor. Many Haitians do not go to the hospital until they are in an emergency dire situation, as they believe in herbal teas and other natural forms of remedies. Another unique need is that after birth, traditionally, like in the hospital, we see that women are, offered water and water ice to continue to drink. But Haitians typically avoid cold water or cold drinks in general, as they believe in taking 3 baths where they are bathed in leaves and hot tea, where they are able to really cleanse their body. So these are some of the unique needs that Haitians have versus African Americans.
Great, thank you. Sandra is asking, outstanding job, Tanesha, to expand on your recommendations. How can policymakers and community leaders, especially those of Haitian descent, foster change within the public health system, especially in communities with higher numbers of Haitian migrants?
Thank you, Sandra, for the question. I think that it is important for policymakers and community leaders to really work on collaborating with communities in general, doing research studies, doing focus groups where they go in and ask questions about what the needs are within the community so that they can start focusing on these goals. It's really about listening. A lot of things with policy and advocacy is listening to what actually exists. There can be perceptions that policymakers already have and community leaders, but without actually integrating the community within that, it will be hard to foster change, especially when Haitians have such unique cultural identities, cultural backgrounds, and especially due to the historical factors, biases, and stigmas that already exist. They're coming to a country where they don't speak the language, they don't know about resources that already exist to them. So it's really about connecting with the community and trying to connect them with resources in the community that already exist so that they can mitigate whatever issues that they may be facing.
Great. Tanesha, I just have a question, and I don't know if you'll know the answer, but it's just something that I've been thinking as you were presenting, but especially in these high cluster cities, to what extent might there be providers of Haitian descent that they can go to? Because that might make a real difference, but I don't know if you have any idea of the answer to that.
I don't know the specific extent to in terms of the percentage of, Haitian Creole speaking providers, but from my experience, Dr. Pardo is a provider of Haitian descent, and there are a sizable number of Haitian providers within New York City, Miami, Boston as well, but it's not enough to the extent to
Yeah, I
cover
suppose
all,
not.
all the
Yeah.
all the Haitians that are within the country, and I mean within those cities.
Within those, yeah, exactly. The long waiting room. Mhm.
Yeah.
Uh-huh. And the last presenter is Tiffany Persaud, who I know. She's one of my advisees. She comes to us from North Carolina State, where she majored in biological sciences. And the title of her master's essay is Barriers to Proper Nutrition on College Campuses and its Contribution to Malnutrition Among Undergraduate Students.
Hi, everyone. My name is Tiffany, and I will be presenting my presentation on the barriers to proper nutrition on college campuses and its contribution to malnutrition among undergraduate students. So characterized by the lack of essential nutrients in an individual's diet, malnutrition causes a detrimental impact on one's growth, development, well-being, and overall health. Despite its damaging nature, malnutrition remains a significant public health issue across the world. While many efforts have been made to address this concern, this public health crisis still continues to impact more than 1 in 3 people globally and 53% of all American households. So it is also important to note that some populations are at higher risk for this condition, specifically children, the elderly, pregnant and breastfeeding women, individuals with chronic diseases, mental health disorders, substance abuses, and even college students are part of these groups that are particularly vulnerable to malnutrition. For these individuals, there are various factors such as limited food availability, dietary restrictions, loss of appetite, difficulty accessing and preparing healthy foods, and just population-specific impaired nutrient absorption that contribute to their increased risk for malnutrition. So while every at-risk population deserves more support, I would love to shine some light on the number of college students that are actually experiencing this public health crisis. Due to numerous determinants that we'll discuss later in the presentation, over 33% of American college students are malnourished, matching the malnourishment rates that impact the general population. Considering that college students only make up a small proportion of the United States population, having over 33% of this population being malnourished is incredibly alarming. In addition to this number, it is crucial to point out that 59% of students are considered food insecure. And it's super important to know this because food insecure is considered having an inconsistent access to meals. And it is also considered as a gateway to becoming malnourished in the future. So considering that such a high number, that there is such a high number of malnourished students, it's important that public health efforts also support these students before they actually develop malnourishment. So to assess malnutrition, to address malnutrition and food insecurity among all at-risk populations, there are several federal programs, including the Women and Infants Children Program, also known as WIC, as well as the Supplemental Nutrition Assistance Program, known as SNAP. And these programs can provide vulnerable families with additional funds to purchase healthy options. And while these programs are great at supporting these populations at risk, it is important to note that many college students are often excluded from these programs. Despite a high number of college students being at risk for malnutrition and food insecure, many nutrition programs actually fail to consider these individuals as vulnerable. And due to this, and just even the general lack of awareness about SNAP eligibility among college students, only 18% of college students have been eligible for SNAPs in the recent years, and only 3% are actually receiving food assistance. And that's for SNAP. In terms of WIC, there actually has not been any research done. And while it's not safe to assume that, there probably aren't students that use this program, it is definitely not talked about at a level that makes it clear that students are getting help from the WIC program. So considering their status as a vulnerable population and the severity of malnutrition, this lack of nutrition assistance for college students is a growing concern that must be changed. So why exactly do these numbers about college students and malnutrition even matter, and how can we address it? To truly answer these questions, it is important that we understand malnutrition is and how it impacts college students specifically. And of course, why this public health crisis is so prevalent among college students. So for starters, malnutrition is considered the lack of proper nutrition due to inadequate nutrient intake, an unbalanced or restrictive diet, or even an inability to absorb nutrients from food. This condition often presents in two main types, undernutrition and overnutrition. Undernutrition is often considered not consuming enough calories or essential nutrients to carry out daily functions. Usually people who have this form of malnutrition are often suffering from stunted growth, delayed development, weakened immune system, and an increased risk of infections and diseases. On the other hand, overnutrition is when an individual consumes an excessive amount of calories and nutrients, causing the body to store extra intake as body fat. And this can often lead to, heart disease, obesity, type 2 diabetes, hypertension, and even stroke. However, despite these differences in, definitions, both under and overnutrition can result in similar adverse health outcomes. From impacts to one's mental health to the physical impairments that are listed in this diagram, both undernutrition and overnutrition have damaging impacts on a person's body and livelihood. So, in addition to the general impacts that the public health concern has on a person's body, malnutrition also presents additional challenges for college students. Considering that one's college years are a critical period of growth, impacts from malnutrition during this time can present both short and long-term impacts. To be specific, short-term consequences can include difficulty concentrating, poor academic performances, fatigue, lower energy level, and more. In terms of long-term, it will be chronic reduction in cognitive function, memory, attention, decision-making abilities, and even development of chronic diseases. So what exactly causes this harmful condition among college students? So unfortunately, college students are at high risk for malnutrition due to a ton of reasons. For starters, malnutrition can often be caused by, students having a limited knowledge of what entails an amount of well-nourished meals. Often these individuals are receiving enough food in general, but they're not sure of the correct nutrients that they should be, leading to them becoming malnourished. Another major deterrent is actually the fact that some students will often not have a consistent access to healthy foods due to living on campus or having a limited number of nearby grocery stores. These students are usually limited to on-campus dining, which may not always be serving the most nutritious meals. And on top of that, they are unable to supplement their nutrition with other external grocery store purchases. In addition to these risk factors, another major deterrent is actually the financial constraints that limit students from purchasing, healthy nutrient-rich foods. According to a recent study, it's found that consuming a healthy diet can cost an average of $1.48 more per day than a less nutritious. And while this number might seem a little bit low, considering such a price difference can easily add up over time, and can easily add up to the financial burden that many college students already face. And the last two include, busy schedules with classes, jobs, and so many other things can just easily impair an individual's ability to, cook food or even eat food. Sometimes they're just so busy they skip meals or rely on fast food and snacks. And the very last one is that, some college students, due to stress, eating disorders, or other mental health reasons, can also prevent themselves from eating. Stress causes cortisol to increase, reduces your appetite. In addition, having eating disorders will, often put individuals in a place where they feel like they should not be eating, or if they do, they should purge it out. And in addition to these causes, I do want to mention that COVID-19 also burdened the, malnutrition across college campuses. Unfortunately, the pandemic has worsened the ever-present concern, with many students already facing financial difficulties, food supply chain disruptions, and social isolation that were endemic to COVID-19. This pandemic has already exacerbated food insecurity and limited access to healthy food options on campuses. In addition, the closure of campus dining facilities and limited access to grocery stores even made it a little bit more difficult for students to even access healthy food options. It was recently found that actually 38% of respondents to a recent study were experiencing food insecurities during the pandemic when they previously weren't, which is actually an increase of 5% from pre-pandemic level. And considering the amount of people who attend college, this is a pretty. So what are the current approaches that are being used to address this issue? So considering the high number of students who suffer from malnutrition, and of course, how the COVID-19 impacted the situation, many colleges around the country have already implemented several measures to reduce malnutrition. And this includes actually, food pantries, having individuals help with SNAP, help students enroll for SNAP, nutrition and gardening programs, and this thing called the Emergency Food Assistance Program, which is essentially a governmental program that essentially gives out grants for students who need the urgent need for food. It is a temporary program, but it does assist with getting quick access to food in emergent cases. However, while these approaches are great, they are incomprehensive and inefficient for addressing malnutrition by itself. So with this said, I would like to introduce the Hunger-Free Campus, which is essentially one of these initiatives that can comprehensively address the numerous causes and determinants that cause malnutrition. While, like I said, it's not solvable by a single solution, the Hunger-Free Campus initiative does allow, many of the determinants to be addressed. So essentially what this program is it's a 3-step program that encourages higher education institutions to holistically support students in addressing food insecurity. The 3 approaches that it uses is creating a step 1 hunger program, establishing campus food pantries, and presenting SNAP enrollment opportunities. And for more specific, what each step is, the Swipe Out Hunger program is essentially where this colleges will help connect students to unused meal swipes from peers, using technology in order to basically move those unused meal swipes to the peers who actually need food. This is really great because this allows students to have ready-made food, which eliminates a lot of the causes that we saw before. It is important to know that by itself, it's not a useful method because it does rely on there even being meal swipes, which relies on students not using them. So it's not a consistent, most reliable resource, and you'll often only be able to use this towards the end of the semester, but it is great for allowing students to have food, especially during busy times like finals and whatnot. The second prompt is establishing food pantries on every campus. In the past, since malnutrition has been a present issue, there are already a ton of food pantries on campus, with actually over 200 campuses having food pantries. But this program just makes sure that, the food pantries are fully stocked and are actually being maintained. It provides funding to these programs, and as of 2022, it's provided over $100 million to food pantries across the campuses. And the very last thing is guiding eligible students through SNAP enrollment, essentially the Hunger-Free Initiative. It either gives funds to the colleges for them to hire a person, or they presents a representative who can help, guide students through SNAP, what exactly it is, and just help any eligible students get signed up. And it also actually, disperses information across campus. So even people who didn't think that they were eligible can also sign up. So considering the benefits and the fact that, the Hunger-Free Campus Initiative already uses programs that are present on campus already, there are numerous colleges across the country that have enacted this intervention. As of right now, there are over 8 states currently carrying out the Hunger-Free Campus, with the first one being California. And there are actually 7 states preparing for implementation in the future. I do want to mention, though, however, while this program is great and it does include everything, Hunger-Free Campus does not support community college, as these programs often do not have a meal plans. However, they do offer some support for these facilities. So with all of this said, this initiative definitely helps colleges across the country. So I would like to end by just saying, overall malnutrition is a prevalent issue on college campuses with significant impacts on students' health and well-being. And it is incredibly important for colleges to address this issue by providing students with consistent access to healthy food, educational nutrition, and healthy eating habits, and just resources to support their students who may be experiencing food insecurity or malnutrition. And in order to achieve this, colleges across the United States should look into implementing the Hunger-Free Campus Initiative. By incorporating this program into higher education institutions, students can look into a future where their nutritional needs are being met through an accessible and comprehensive approach. So I just want to say thank you, and a special thank you to all my mom, my dad, my siblings, and Timur and Uncle Jer, my friends Anish and everyone else. And thank you, Dr. Amari, for being my primary reader and my advisor for the past 2 years, and Ms. McCormick for support even before I started the program.
Great. Thank you so much, Tiffany. To what extent has this issue worsened or changed as a result of the COVID pandemic?
Yeah, so malnutrition, due to the COVID pandemic, as I feel like everybody is pretty aware of this, there were a ton of food chains disruptions. A lot of grocery stores either had reduced hours or were closed, and a lot of just on-campus dining options, specifically for college students, were also closed due to, social isolations. Because of this, pre-pandemic, the rate used to be 33%, and then during the COVID-19 pandemic, the percentage actually went up to 38% of students just being malnourished. Food insecure wise, that is another issue that can lead into malnourishment. As of right now, there has not been a consistent number, but I've seen numbers ranging from 25 to 75%. Regardless, that is a big number, even if it's just 25% of students becoming more food insecure during the pandemic. And so considering this, it's very clear that the COVID-19 pandemic definitely worsened the situation of malnutrition and even just food insecurity on college campuses.
Mm-hmm. Okay, I see Stacy.
Hi, so really great job, Tiffany. I actually have 2 questions that are a little bit different. So my first question, something that I'm really interested in is like how the overlap of how malnutrition is experienced, like symptoms of malnutrition overlaps with a lot of how people with disabilities, specifically neurodivergent people, experience things. So like the food aversion, difficulties with memory and attention. So do you know if in those studies about college students, if they also looked at disability, so like if those college students were also disabled?
So as of right now, no, I have not seen any ones that are specifically for that. However, I did notice this is not at all super credible, but on the Hunger-Free Campus Initiative, they do actually have several social media pages, and I've noticed recently, especially around Disability Awareness Month, they were posting more foods that they were encouraging their food pantries to be aware of, and just general information about students who are, neurodivergent. And so it is not, of course, anything in terms of like related to research, but it is important that they are thinking of that, and hopefully in the future they can consider these populations a lot more when, trying to do changes for this program.
And then my second question is specifically about the connection to SNAP aspect of the Hunger Free program. So SNAP is great, but we also know that there are a lot of places where people fall through the cracks, so especially like college students. So my question for you is if you have any suggestions or ideas for ways to like have a more systemic level of change within the SNAP program, because I imagine like referring people to already a program where they would fall through the cracks may not be as helpful. So any ideas for suggestions to improve the SNAP program at a broader level?
For sure. And so this program more so specifically focuses on it's like 18% of college students are actually eligible for signing up for SNAP. So it is already a super low number. And so the SNAP program, the Hunger-Free Campus Initiative, what they try to do is basically work with the students, by disseminating information about SNAP and just trying to see if anybody can even recognize that they're eligible and then helping them through this. But considering that that number is really low and a lot of students can fall through the gap, this program does try to supplement by, like also highlighting like nearby nutrition assistance programs. The one in California specifically, since it is the first and the largest, several of their campuses have actually also referred students over to like local food banks or local, soup kitchens to help out. Granted, it is not a systemic solution by any means, and I don't believe that Hunger Free Campus Initiative is at the place where they can do that just yet. But I do know that, at the moment they are trying their best to like basically cover any gaps that they can find by the three-pronged approach, or even just using like community-based initiatives.
Thank you. Great job, Tiffany. I just had a quick question, just going off of the Hunger Free Campus Initiative. So because this includes college students that are also enrolling for SNAP, but that you talked about that, how that eligibility for SNAP is going to end soon. Do you have any ideas of how you think that this program can kind of support individuals or students that maybe rely on this program and now won't have it any longer?
Yeah, definitely. So it is important to know that this is actually just kind of general, not even just nutrition based. Oh, sorry, not even just nutrition based, but with essentially basically a lot of like the COVID based grants, nutrition grants, all the things that happened during those times, they're coming to an end starting next month actually. And SNAP will also be impacted by this. Actually, it's those who got like emergency funding through SNAP during the COVID pandemic are actually now seeing that they either have to be reevaluated or they're losing their, temporary emergency fund assistance. And considering this will impact a good amount of students because it actually helped college students who, could not use college dining campuses options to get food. So considering that a lot of these students might lose access, this program is actually aware of that. And they recently have put out a statement saying, they will continue to enroll people as much as they can, but they are looking for a way to broaden, just basically not broaden, uplift their other two approaches to at least supplement those who are losing that access. And one really cool way is actually, this is mainly happening in California and also in Pennsylvania, which is actually the second state that enacted this program. These two states specifically are looking to, have now equipped their food pantries with actual cooking supplies. In this way, they have pots, pans. They're even adding access to an actual kitchen so students can come there and cook. Granted, it, may not be the best for those who are super busy. And so it doesn't solve that approach, but at least it helps give students, as much means as possible to cook food, and definitely supplementing those students that are losing access within the next few months.
I want to thank everyone for your presentations. This was an amazing session. And we are now concluding our 2023 master's essay presentation. So give yourselves a round of applause. Wonderful job.